Hi everyone. Thank you for those who introduced themselves in the chat. We're going to start now the webinar. Welcome to our first webinar of the year. My name is Valeria Flores. I'm part of MHPSS.net team, and I'm going to give the floor to Sean, who's going to start the webinar for everyone.
Hi everyone. Thank you MHPSS.net for hosting this webinar with us. Happy to know that it's the first of the year. So today the webinar will be presented by our two speakers, Anna, who is a licensed worker and a research associate from Department of Mental Health from the Johns Hopkins, and from BOFA, who is a mental health professional working in Liberia and is currently the mental health and psychosocial support head of department for action against hunger. Next, please. And so the webinar is about the adaptation process of the ReachNow tool that has been developed in collaboration with different stakeholders, including the Ministry of Health of Liberia, Labs or Association, and LICORMS from Liberia, and also with War Child. And so for the implementation aspect also, BOFA will discuss and share with you some of the findings with the use of the tool in Liberia. Yes, so for the agenda, we have Anna, who will present the first section on the adaptation process. And then BOFA will share the experience in Liberia about the implementation and the rollout of the ReachNow tool. And then we will have 10 to 15 minutes Q&A session with you. Thank you. And the floor is yours, Anna.
Hi, thank you, Sven. So the ReachNow study came out of discussions with the Ministry of Health in Liberia and key mental health stakeholders led by ACF. So yeah, thank you for this opportunity to present. Excited to present. In Liberia, the mental health system is fragile and under-resourced, and so to help be able to identify children and adults with mental health problems, the ReachNow tool was chosen to address kind of the demand side of seeking care and was then adapted. So next slide. So the ReachNow, just to kind of give a little bit of background. So War Child developed the community informant detection tool for gatekeepers to be able to identify common signs of mental health problems in their community. So for schools, religious institutions, community-based organizations, to be able to see people in their community who had mental health problems and then refer to care. You can go next slide. So just to kind of giving a quick background, but so the tool was not intended to be able to diagnose, but just as a simple kind of vignette with a short story and images, as you will see here, to be able to then have community members, look at people within their community and then refer to care. So for in Liberia, next slide. So in Liberia, Action Against Hunger, in partnership with Liberia Center for Outcome Research in Mental Health, Liberia Association of Psychosocial Services in the Ministry of Health came together to implement the ReachNow study in consultation with War Child. And there were two kind of main goals of our study. So it was first to kind of culturally and contextually adapt the case vignettes, and then to assess their acceptability in Liberia, following the War Child's adaptation process that they've created. Next slide. So as the result of this study, we developed two vignettes for children, one for internalizing behaviors, and then one for externalizing behaviors. Next slide. And for adults, we adapted 4 vignettes, one for depression, epilepsy, psychosis, and then substance misuse. Next slide. So the ReachNow adaptation process, which is kind of the kind of key reason for holding this workshop today, was to kind of describe the 4 phases that were used to adapt the ReachNow tool for Liberia. So in March 2024, we held a ReachNow adaptation workshop in Monrovia with mental health stakeholders. And then from there, we developed the vignettes with a small team from April to June 2024. We did field testing in the community with focus group discussions in July 2024. And then we held a validation workshop with kind of experts in Liberia in August 2024. Next slide. So the adaptation workshop had 21 participants from Liberia who participated in it. We gave an overview of the tool, of the kind of the purpose of the ReachNow tool to local stakeholders, and then we had a free listing exercise where the participants identified mental health problems that they see in Liberian context. And we did this first for children, focusing on internalizing and then externalizing behaviors, as well as for adults, we identified common mental health symptoms, as well as kind of more severe mental health symptoms for adults. The participants then ranked the most kind of common signs and then prioritized through kind of a group discussion on which ones should be used to develop the stories. Small groups then formed together to draft stories that would be relevant to the local context, and then local kind of idioms of distress were identified and included in this story. The group decided that using Liberian English would be the most approachable for the Liberian context, and so we did not do any further translation, but just decided to do the Liberian English. Next slide. So this is just kind of an example of the results of the free listing that were used, that were taken kind of from the workshop. This is for child internalizing behaviors. You'll see how we kind of group the similar kind of signs together. We kind of then, counted kind of the number that each one kind of represented, as well as whether or not the group had decided in the discussions whether to prioritize it or not. Next slide. So kind of from the outcomes of the workshop, we had the free listing results, as well as drafts for each of the vignettes that we wanted to develop. Next slide. And so the second phase of the adaptation process was the development of the vignettes. So taking the inputs from the stakeholders at the workshop, we then created a design brief. And there were multiple kind of rounds of feedback with the designer to be able to kind of guide him in developing kind of the layout in accordance with War Child's guidelines, as well as creating the images that would represent the signs of mental health symptoms or mental health problems that we wanted to make sure that were included. So you will see to the right, we had kind of different feedback, kind of a round of feedback with one of the vignettes. Next slide. So this kind of just gives a little bit of a big picture kind of the process, the iterative process that we took. So from kind of the design brief to then the illustrator being able to kind of show us the different images that he was working on, and then we would give further input as a small team. We also had decided to use some of the story and examples from a prior community implement detection tool that was used for epilepsy in Liberia, and so we kind of updated it and adapted it to the kind of current ReachNow kind of template for the tool. And then we had kind of a final review of the vignettes before we took them for field testing by War Child, as well as the leads at ACF. Next slide. And so just some kind of key lessons learned or kind of findings or recommendations that we had from the design process. So we learned that it was really important to start small and be consistent, that having, multiple signs of mental health problems can sometimes going to be a lot to review and to give feedback on. And needing just to plan for additional time for, experts to kind of review the illustrations and make sure that they're aligned with both the cultural context as well as just mental health, mental health symptoms for different diagnoses. And then we also just found that it was really important to decide culturally how gender would be represented in that balance. For Liberia, we decided that it was best to only have one gender represented in the vignettes for clarity and understanding, kind of for the community. In other contexts, they'll have both, or they'll have different other genders represented. And so for Liberia, we just decided to have one for each story. And so then the third phase, next slide, was the field testing. And so for the ReachNow tool for each of the vignettes, so all 6 vignettes, we took them to the community and we did focus group discussions with participants. And we really tried to find participants who would represent people who could use the tool. So you'll kind of see the different workers or the different people identified that were involved in the process. In total, we had 55 people, and Zainatown and Sinuan represents both rural and urban contexts. And we really wanted to get both perspectives, which is representative of the people who we would hope would be using the tool in Liberia. And so the participants, they gave feedback on the interpretation of the illustrations, what they thought the illustrations meant, and we would do it one by one, showing them images and then what they thought of it, and then as well as the story and whether that made sense to them and was clear, and any feedback that they had for each of the stories. And then for the overall vignette, just the clarity and understanding of it. The participants overall found that it was understandable. There were some minor changes or suggestions to make some of the images more clear, or to switch an activity if it wasn't relevant to both an urban and kind of more remote context. But overall, they found it to be understandable and could even identify people in their community who they thought matched that. So we found that it was appropriate and kind of acceptable to the community. Next slide. And so kind of as I have just kind of described, here is kind of some pictures of the focus group discussions, and as well as just kind of the main outcomes, so that it was understandable for the community, that there were some little changes to kind of improve the vignette, but no kind of major changes to the overall stories or the mental health signs that were communicated. Next slide. And so the kind of the last step in the adaptation process was the validation workshop. And so for the workshop, we invited stakeholders from the Ministry of Health of Liberia, from the Ministry of Education. We had people with lived experience of mental health, as well as program implementers and potential end users who were working at the community level. And so this kind of group of experts were the ones to kind of review the focus group discussion feedback and to decide kind of what the final vignettes would look like, what changes would be made, what would not be made, what was necessary or unnecessary. And so kind of, one example of kind of a change that was made was for Liberia, they felt that it was better to be more specific and to say refer to a clinic at the end of the vignette instead of say just refer to help seeking in general. So they wanted to have more kind of concrete instructions for the participants or the users of the vignettes. And then there were some other kind of minor changes that were made to vignettes. So, to kind of, in conclusion, I guess next slide, We really found that the ReachNow process was a very easy process to use for the adaptation. War Child's guidelines were very clear and gave support throughout the process. So we're really thankful for Mirta and the War Child team for their support throughout this. And the tools for Liberia were found to have face validity and to be culturally and contextually acceptable to community members, the mental health stakeholders, as well as the Ministry of Health. And, post kind of our adaptation process, the vignettes have been finalized for use on the ground, which Bofa will next share about. The team, after we developed the vignettes, were then provided kind of implementation guidelines by War Child to be able to kind of use in Liberia and to be able to train trainers in the ReachNow tool for the implementation. And then at the workshops, or kind of during the process of the adaptation, ACF was able to talk to the Ministry of Health about incorporating the ReachNow tools within their community health program, which was like very exciting to see that outcome and just kind of uptake so quickly to be able to use the tool in Liberia. And then the study team has also kind of disseminated the findings from the adaptation tools. So we've presented at the European Society for Prevention Research this past September. We developed a 2-pager that we'll kind of share with this webinar later on when it's posted on YouTube. And then there's also a presentation that we will be doing in July at the Association of European Qualitative Researchers in Psychology in Lyon. So we are really pleased that we could share our adaptation process with you today. And I'm going to turn it over to my colleague Bofa in Liberia to kind of to share about the implementation process. Thank you.
Okay, thank you very much, Anna, for your presentation on the adaptation process. Hello again, everyone. My name is Bofa Washington Beslow. I work for Action Against Hunger in Liberia as the head of the MHPSS department, and I will be presenting on the implementation process of the ReachNow tool. Next slide, please. So, following the adaptation workshop, ACF made a presentation on the implementation strategy of the ReachNow tool at the monthly National Mental Health Technical Coordinating Committee meeting of the Ministry of Health. And this meeting is where all mental health stakeholders in Liberia meet on a monthly basis to discuss key mental health issues and also share their achievements. During this meeting, it was agreed by all stakeholders that the ReachNow tool should be adapted as a national community mental health case detection tool and be used by all of the organizations in Liberia that are implementing community-based mental health programs, rather than it being considered as a tool that will be used only by ACF. So based on the consensus from that meeting, the director of the mental health program in Liberia proposed that we have a meeting with the National Community Health Services Program Director and his team to discuss means on how we could integrate the ReachNow tool into the National Community Health Assistance Program. So we had this meeting with the director and his team, and they also thought that the tool was good and that the proposition was great. So they suggested that ACF collaborate with the core team that was been working currently on the community health assistance curriculum revision process. So in November of 2024, ACF was invited to the curriculum revision workshop in Bikano, where we did a presentation on the tool to the core team that was working on the mental health module. The team, upon the presentation of the ReachNow tool, they actually did appreciate the tool, and they thought that it was a breakthrough for them because one of the core team members stated in a quote She said that since the inception of the National Community Health Assistance Program, we struggled to have job aids that represented mental health conditions well, and that the ReachNow tool has actually filled that gap. Next slide, please. So we then decided to have a TOT for the master trainers at the national level. After the tool was accepted, it was successfully integrated into the mental health module as a job aid for the community health assistance. The curriculum development team at the Ministry of Health needed to be trained as master trainers on how to implement the tool. Therefore, in December of 2024, a total of 21 participants comprising of 15 core team members from the Ministry of Health and 6 participants from 3 of our partner organizations were trained and certified as national mental health trainers on the ReachNow tool. Next slide, please. Following the national level TOT, the Ministry of Health was actually meant to conduct the council level master trainers training, but there was some delay. So ACF decided to pilot the tool within its project locations of Monserrado, Margibi, and Nima counties. And we decided to pilot this tool not with the community health assistants, but rather with the community health promoters, which are the CHP, because these were the community groups that we currently work with in our project locations. So in June of 2025, we work along with the Community Health Services Department of the Ministry of Health and the county health teams of the 3 counties in which we work to train 63 community health promoters. So of these, we have 17 trained in Margibi County, 19 trained in Monserrado County, and 10 trained in Nimba. And the purpose was for them to use this tool in community case detection and referral within 63 communities of our project intervention sites. Next slide, please. Thank you. So when we completed the training of the community health promoters in June, we actually did inform them that they will receive hard printed copies in color so that they could begin using the tools in their community for case detection. However, due to some logistical issues, the tools were printed and distributed in September to the community health promoters. And so, considering the gap that we had between training in June and then distribution in September, ACF provided ongoing support by mentoring and coaching the CHPs on how the tools should be used. And we also provided them some tools for data collection and reporting. Next slide, please. Okay, so after we had done the training for the community health promoters, the Ministry of Health was actually able to finally mobilize resources to conduct the training of the county level master trainers on the competency-based curriculum for the community health assistance. And the community health assistance curriculum actually does comprise of 6 modules, of which the mental health module is one. So there are 6 modules for different thematic programs. So it's a comprehensive package that was used to actually train the county level master trainers in December 2025. So ACF was represented at this training by our health and nutrition HOD, who participated in a 10-day TOT along with over 100 other participants who were also trained as county level master trainers to cascade the training at the community level. So for the Ministry of Health, The next phase that they have to roll out this competency-based curriculum is to now train the community health services supervisors, who would subsequently be the ones to train the community health assistants at the community level. Next slide, please. So we have been able to gather some key achievements from the field so far after we distributed the hard copies of the tool and the data collection and monitoring forms to the CHPs in September. So for the key achievements so far, the community health promoters have reported having increased confidence in identifying mental health cases within their communities and helping to encourage family members to take their loved ones to the clinic for support. A community health promoter in Nima County stated in a quote, he said that before I did not know that I could go to people who have mental health problems and talk to them about going to the hospital or the clinic. I used to be scared to engage them because I thought they were dangerous. And furthermore, I didn't know what to say and thought that there was no help for them. But with the training we received and the ReachNow tool, I am able to identify suspected mental health cases in my community and encourage them to go for treatment. So with this testimony, we see that this has actually helped to increase their level of confidence in being able to actively identify cases within their communities and refer patients based on consent for support at either the clinic or the hospital. So as of October 2025, we were able to receive monthly reports from over 50% of the community health workers, which is 36 out of 63 of the community health promoters who were trained on a ReachNow tool. And from the reports that we received, so far they've been able to identify 34 mental health cases across the 3 counties, covering 7 of the 9 districts in which we work. And of these 34 mental health cases that have been identified, 12 of them were depression cases, 6 were psychosis, and 2 were epilepsy. However, we received 14 cases that were also unspecified. So this means that we do not know exactly which of the category of mental health conditions these 14 unspecified conditions belong to. And also, we did not receive any data on the cases for children, especially that on the internalizing and externalizing behaviors. Of the total 34 cases that were identified, 10 of those cases were reported, 10 of those cases were referred to the health facility for support, and that represents 29.4% of the cases referred. Next slide, please. Okay, so there has been some challenges we've noticed or we have identified from the implementation of the tool. And though the data that I just presented is for only 1 month, that is the month of October 2025, there are some challenges that we have identified, and I would like to share this with you along with some recommendations to mitigate these challenges. So from the community health promoters' perspective, one major challenge they encounter is limited support and supervision from their supervisors, who are the CHSS we call for short. And they noticed that these community health service supervisors have shown little to no commitment in helping to supervise them or even in recording and the documentation of the cases at the community level. And also some of the communities where we intervene are remote with limited network connectivity, making it difficult to actually communicate with either the community health promoters or their supervisors, and even our project supervisors, wherein we may need to either verify or call to collect data on information that they report. Another challenge we face in the implementation of the ReachNow tool is limited HR. So for example, we have 1 PM to monitor all of our MHPSS activities across projects. And also reporting is another challenge that we have identified. So because the CHPs have actually mentioned that they do not have the necessary support they need from their supervisors to actually be able to report the data, this has also presented some challenges in reporting. So for example, if you noticed in the data that I presented on the previous slide, 14 of the cases reported are unspecified. And also there are no data on children cases. The data that we received is now being disaggregated by sex, and the number of cases referred is low, because this is one of the reasons why we adapted the ReachNow tool so that it will be able to identify these cases and encourage health-seeking behavior. But we see that, the number of cases being referred, 10 out of 34 is actually low. So we try to draw some hypotheses as to why the referrals are low, and we believe that this could be attributed to some situations that were cited by our team members. So for example, they stated the workload of the community health promoters, since these community health promoters are not only doing MHPSS work in the communities, they're also doing work in SRH, nutrition, and so forth. Another probability could be, the lack of family support and transportation to seek care for our patients, and also the introduction of the fee-for-service scheme by the Ministry of Health. So before May 2025, most of the services at all government health facilities were considered to be free. But due to the USAID funding cuts, the government introduced a fee-for-service scheme, which requires that patients will have to pay for services that they seek at these health facilities. So this has also reduced the health-seeking behavior at the health facility. And most interestingly also is the constant stock out of psychotropic medication at these facilities. So usually the awareness is being created. People are encouraged to go and seek help at the health facility, but in many cases, when you get there, they are told where we are stuck out of psychotropic medication. So this could probably be some of the reasons why the referrals to the health facilities were low, but we anticipate to actually make some follow-up and probe into other reasons why, the referral was that low. So to help mitigate these challenges, we have proposed the following. One, we intend to work with the district and the county health teams who would provide ongoing such support to the CHPs in the absence of the CHSSs. And also we hope that our ACF program managers, as well as the project supervisors, they need to have increased engagements with the community health promoters to ensure that they are using the tools correctly, to also help to clarify any confusions that they may have, help to reinforce the reporting standards to support accurate and complete data collection, as well as reporting. And finally, we hope that we can facilitate discussions with these community health promoters within their communities so that they can assist in identifying opportunities within their communities and leverage on them to help increase referrals to the health facilities. So I think this should be the end of my presentation. And I want to say thank you all for your attention. And we will now take questions and answers.
Thank you, Anna and Bofa for your presentation. There is some questions that were collected that I will share with you. Just before that, what I would like to say is, as you can see, like in the presentation, like the difference between like the whole adaptation process and then the rollout and operationalization, sorry, of the tool was quite challenging. You can see that we did face like between logistical and practical problems in terms of implementation, and now to make sure that in terms of programmatic and implementation and use of the tool, and that we can ensure the quality and make sure that it is used properly. So we are trying to address all this. So from the question raised in the room, there are some related to the adaptation process itself. So this is for Anna. What were the most time-consuming or challenging steps of the adaptation process? Just wondering from the point of view of someone who might want to rapidly adapt the ReachNow tool and not to a novel context during a humanitarian emergency. This is for Anna, but of course, Bofa and I, we can contribute also to this. But Anna, maybe in terms of most time-consuming or challenging steps, according to you, what would that be?
Yeah, so I think, I mean, for the whole process, the guidelines that we were given by War Child, we did our best to follow them as much as we could. And yet what we found was that some of things just took longer because of needing, consensus with stakeholders, and particularly the design process. I think originally we had planned for maybe a month at most to have to do it. I think it got extended. So that definitely is a challenge, just making sure that the vignettes reflect both what was, recommended by the participants in the workshop, as well as that what they're representing is what you're wanting them to represent. And so there were certain, signs that were just a little bit harder to represent and to make sure that they were clear. And so we had many kind of iterations of that. So, I would recommend having a really, a designer and core team who has the time to be able to, meet. And so if it is a very rapid, adaptation process, just all hands on deck, and to make sure that there's enough, effort by everyone to be able to kind of give that feedback and insight.
I mean the adaptation, like in terms of timeline for a humanitarian emergency, I think it's not really feasible. I mean, if it's like immediate response, say you have an earthquake or inundation, I mean the flooding or something, you don't have like a time to properly, I mean, we did really like the adaptation process to, validate the tool as like qualitatively, with involving like many stakeholders, back and forth, testing. So I would not recommend trying to adapt it for like a very immediate emergency response. Here, like Liberia is a development context, but I'm sure our colleagues, I mean, and other MHPSS stakeholders from Ukraine or other countries where the tool has been adapted can maybe also, provide some advice on how to adapt in like humanitarian settings. But I would not say like emergency, like a super urgent context. Another question is, could you give us an example of a challenge you face in terms of reflecting cultural idioms of distress in your adaptation process?
Sure. So I think one that comes to mind is in Liberia, people often use the term open mole as a description of mental health symptoms, and a lot of it's somatic symptoms that they're describing, but in association with more depressive symptoms. And so that was a little bit, I guess maybe challenging to be able to just show in an image what that means. So we had different kind of, ways of doing that, different kind of input on what that would look like to kind of describe that. And even from just like how much of the head was to be shaved and what color, for like the leaves that were to be put on the head, that is often done when people have open moles. So I think that was just kind of a contextual kind of cultural idiom that took some rounds and kind of feedback and input to make sure that that was reflected in a way that people could understand what that meant. So that was just
maybe Bofa, you can
if you have another one.
explain further what open mole is, and then graphically how we had to design it on the vignette itself.
Yes, thank you. So Anna is actually right in describing the open mole that is actually being associated with depressive symptoms. However, clinically, we've also seen symptoms of anxiety also being associated with open mole. So that constant palpitation, lack of sleep, fear of being harmed, and so forth. And sometimes constant worries as well has been associated with the open mole. So drawing a clear line between the symptoms to be able to say, okay, this could represent a diagnosis of anxiety or depression has also been a bit of a challenge in trying to identify this cultural syndrome, because open mole is actually a syndrome. So it's not a symptom alone. So it's a syndrome of several symptoms put together, which is described. And physically, how it manifests is that the individual will complain of persistent headache, and they will also complain that their frontal lobe is actually sunken and palpable, as you will see in children who have their frontal nails open. So they will definitely tell you that my frontal nails are open and it's palpating and I can feel it. But typically when you and I do our physical assessment, there's no sunken frontal nail, and usually the frontal nails are all closed. So these are some of the cultural representations of clinical idioms in Liberia representing open mole, depression, or anxiety.
Thank you. Another questions, related to like normal distress, and then were there any safeguards that you had to put in place to prevent over-labeling people with normal distress symptoms as people having mental health disorders during the implementation, Bofa? Because what we did actually, go ahead.
Yes, so the tool is not used for diagnosing, as Anna presented earlier. So it's actually used to prototype and identify symptoms that may be similar to those conditions within the ReachNow tool. So we only encourage our community health promoters or the community assistants to identify individuals or adults or children within the community who may have symptoms that are similar to these conditions. And once they are referred at the health facility, that is where we have trained mental health clinicians who perform a comprehensive assessment. And based upon that assessment, they will be able to come up with a clear diagnosis. So they are able to distinguish whether this is just a sign of distress or this is a mental health condition.
And in addition to the tool, what in terms of activities in the project, we do have like awareness sessions within the community to provide, like broader information on what is MHPSS and mental health condition. Using, we adapted some tools from NSF about community awareness on mental health disorders. So there are some kind of also psychoeducation to show what are the normal, like distress symptoms compared to someone who have like more severe symptoms and distress. So it's not only providing the tool it alone, but there are also like other, like a holistic approach, working with the community to increase the sensitization and also to reduce so the stigma, which is another question that we have here. Is stigma a common issue for accessing mental health support? If so, how did ReachNow navigate this during implementation? How did it help the CHPs overcome their own stigma towards mental health to support the implementation process?
Yes, so to respond to that question, stigma and discrimination is a very prevalent issue affecting mental health service, utilization in Liberia. And this is not just limited to the countries in which we intervene, but this is a national issue. And we have recognized that as one of the key interventions we need to be able, one of the key things or issues we need to address. So one of the ways we have tried to combat stigma in the community is by working with service users group. So during the adaptation process, we also did include them. So we have one popularly known one as the cultivation for users group. So we involve them into the adaptation process on how we could, ably represent issues that may be associated with stigma and discrimination. And we also do engage them in developing awareness messages that we can share at the community level that will help to combat stigma and discrimination. With the use of the ReachNow tool, we have done a lot of training. So doing the training on the ReachNow tool, we did not just train them on the implementation. The reason I did not focus on that during the presentation of the implementation is because we were presenting on the ReachNow tool, but we have our mental health flip chart, community awareness flip chart, which we have developed that has a lot of information in it that these community health promoters are using within their communities to host regular awareness and sensitization sessions amongst the community members that help to create information about mental health and also respond to some of the issues that we have. And amongst the CHP themselves, of course, there was self-stigma and there were also stigma towards persons with mental health problems. So if you also reflect on the code that I shared, I recall that during the training, one of the CHPs mentioned that for people with epilepsy, because here a lot of people believe that epilepsy is contagious. So they would stigmatize them, they wouldn't allow them to go to school, they wouldn't allow them to eat with other people and all of that. So the information that we provide helps to actually dispel some of these major stigma, amongst them, and then regular information and engagement with the community.
Thank you. Maybe related to like stigma and then maybe also like the belief that can exist in the community. Were there any conflicts with this method? So I guess it's the ReachNow tool and traditional healing methodologies that are more acceptable at the community level. If so, how did you navigate that?
Yeah, so during the adaptation process and the field testing, we engaged traditional healers as well as religious leaders, because these are optional sources where persons with mental health, conditions would go to seek help. And they believe that these religious leaders or traditional healers have, something we call an explanatory module, where they will explain to them that, you have been bewitched, or you may have, broken some law, or so that they connect to. So we involved them in the process, and they were also able to contribute and share their perspective on how we could ably represent the cases that are in the vineyard. And whenever we do our awareness sessions, we do our trainings at the community level, we involve them. Just recently, before the Christmas and the New Year break, we actually had a community engagement and discussion sessions with the community leaders involving these traditional healers on developing an SBCC message that will go along with the ReachNow tool and the community awareness flip chart that we have. So we involved them in it to develop culturally appropriate messaging, and also we check for acceptability, what that we could use to be able to raise the awareness and combat the stigma within the communities.
There was another question, maybe a bit similar, like how does the ReachNow tool integrate with existing community-based mental health approaches in Liberia, just in case they exist?
Okay, so for Liberia, we haven't had like a standardized tool. So every organization who has ever up to now implemented community-based mental health program came with their own tools on how they want to implement community mental health. So there were no, one tool or standardized tool. So for us, our approach is to align all of our interventions with the national level, that is the mental health unit at the MOH, and see how we can integrate our interventions into the national program that can be scalable. So when we engaged them, they accepted the idea that we could work together to develop this tool. And since there was no, there wasn't any tool that was standardized, they were happy to accept this too. And one of the factors that contributed to that is because majority of the actors in Liberia, we really do not have a lot of mental health actors in Liberia, but those who are currently implementing mental health services in Liberia were involved in the adaptation process. So they were part of the development and adaptation of the tool. So when we presented it at the Mental Health Technical Coordinating Committee, they already had that ownership of the tool, and they feel that this is our tool that we develop. We put in everything that we want to see. So it was easy for them to, come to a consensus and say, okay, yes, those of us who want to implement community-based mental health programs can use this tool because it contains what we will be looking for at the community level. So that was one. And then another one, again, another opportunity that we, leveraged on was at the time of the validation, the ministry was then revising the National Community Health Assistance curriculum. And in that curriculum, they have a mental health module. So they had some information, but as it relates to job aids for the CHA, none were actually available. So with the presentation of the ReachNow tool, they were happy to easily integrate that into the curriculum.
Another question is about more how the engagement of the CHPs. How did you gain buy-in from CHPs to conduct this work in addition to the work they are already doing?
Okay, thank you. The CHPs, the way the structure is set up at the national level is that we have the CHPs who are community health promoters, and they work within 5 kilometers of the health facility. So they have already been there volunteering and providing these services. So all they needed was the training and the right tools to be able to do their job. So these were already spelled out and specified in their roles and responsibility as part of the work they will be doing. So that was why we just built their capacity and provided them with the right tools that they could use.
Okay, thank you. There are 3 minutes left and there are still so many questions. Maybe one about the cultural adaptation again is how does the ReachNow tool accommodate different literacy levels and cultural perceptions of mental health?
Okay, so for the case vineyard, I will allow Anna to maybe speak more on that, but how it actually accommodates different literacy level, especially in the implementation of the ReachNow tool, is that the CHPs were trained per county. So we did not, train in Monserrato and then assign them to those different counties. So one, they all reside in the counties where we implement, and they also are from communities where they work. So that means they actually do speak and understand English, or our common Liberian English, which we call the colloquial. They all do understand it, and the ReachNow 2 is simplified to that level. And then they read and then interpret. If the community cannot speak either the colloquial or the English, they interpret in their local vernacular. So that's how we have managed, from the implementation to accommodate the different literacy levels.
Anna, would you like to complete?
Yeah,
or...
and just for the cultural kind of perspectives and different I think perceptions, we really tried as best we could to have diverse stakeholders at the initial adaptation workshop, as well as we were incorporating the different idioms of distress or the ways that people communicated, making sure that the language was as simple as possible and approachable to community members. That's why we did the field testing for the focus groups with people who didn't have mental health backgrounds, who were able to kind of listen or read the vignettes either way, and to see if they understood that. So kind of the whole adaptation process really addresses different perspectives that hopefully help raise any issues with a difficulty kind of understanding that.
Okay. Maybe one last question. I mean, there's two questions in one about more how in terms of the enabling factors in terms of like health systems, but also what from the health system could affect the use of the case detection tool. Here it's so what other factors in the broader health system facilitated use of the ReachNow tool? And the other question is, how do health system factors like staff capacity, referral system, and service availability affect whether cases identified by the ReachNow tool receive timely and effective care? So yeah, it's about the factors from the health system that could facilitate the use of the tool or not.
So I think just to say one quick thing, I know we're at time, so we'll make it brief and then I'll let Bofa add to. It's just that when you're identifying where to implement the ReachNow tool, it's really important to make sure that the health systems are already in place that can utilize the tool. So I'm not going into communities where there's no mental health services, making sure, right, that the clinics are, staffed with people who can treat people with mental health conditions is a really important kind of initial step in the whole adaptation or in the whole implementation process. And so without that, it's really not recommended to use the tool. And so I think proper training and really understanding of where the tool is appropriate to use, where there are resources that the tool can work well within, and where maybe it's best to wait until kind of other systems are put in place. Over to you, Bofa.
Yes, so based on those guidelines that Anna spoke about, we ensure that all of the health facilities where we have CHPs assigned to received training on the MHPSS, so that when patients are referred from the health facility, they will be able to have staff, trained and with the capacity to conduct mental health assessments. So we ensure that we worked with the Ministry of Health that, at least one staff. We actually targeted 2 staff just in case there's staff attrition, we'll still have another staff who will be available to provide the services. And we also are working along with the team to develop, they have actually developed it, but it hasn't been finalized, a formal referral system through the National Community Health Assistance Program, where patients who are identified are actually being referred. And the good thing is that the CHPs are not very far from the health facilities, so they are within 5 kilometers of the health facilities. So they are able to access the health facilities. And if there are barriers that, prevents them from accessing those health facilities, we then want to be able to assess the barriers and see how we can work to mitigate them. And one of the barriers that I mentioned about the constant, time.
It's time's up. We are over
Okay.
3 minutes already. I'm sorry. I think we have to close here. Thank you very much. Maybe Ananda, Valeria, I'll let you close. I'm sorry for that.
No worries about it. It was very interesting to listen to you answer all the questions. Well, thank you first to Sean, Anna, and Bofa for this excellent session. And also thank you to everyone who joined us today. We will be sharing the webinar recording on our YouTube channel and also our social media platforms. And we hope to see you again on our next webinar. Thank you all.